first believe you have a value to give. It's not about that agreement.
I love that.
It's not about that document. A lot of pharmacists are still unsure that they are valuable because, especially in the community setting, we've let the profession divide pharmacists to say who's cool and who's not, or you're clinical, you're not. So I'm learning that there are a lot of pharmacists say, well, but I'm not clinical. And I said, how did you get through pharmacy school without any clinical content? It's impossible. And they go, well, you have a point. I said, who made you believe that? That is the fundamental, that's a problem.
Right.
Because no one just told you, here is Tylenol, without you knowing clinically who can get it, who cannot get it, what are the dosing. So why did we take that out of like it's not? So that's the number one, that pharmacists have to rebuild their knowledge, but also remind themselves they are clinical. Our settings could be different. Mm-hmm. So if my setting is community, so I have different access points, I have advantages and I have disadvantages. The pharmacists in the hospital could say they're clinical, but they have advantages and disadvantages. They don't know where these patients live. They don't see them after the patient leaves the hospital. They don't know that what else is happening. So we need all of us together to manage the patient. So if we can start working on, before collaborating with another profession, we need to collaborate within the pharmacy space, right? If I'm a pharmacist in the hospital setting, I should know who my community partners are and lean on them to help me with the patients, right? So that's number one, that I feel like we need to get our pharmacists believing in themselves again, rewiring that lie that the story they told themselves is not true. They are clinical. They're very valuable. They just have to know what is their value. Then take that value, package it. People don't buy products. These providers are looking for solutions. So then you need to understand their world, right?
Yeah.
You have to understand their world, because you can't sell the same solution to everyone. So if that provider doesn't have that problem, you just lost them because you didn't take the time to know more about them. Right? So I listen more than I talk to these providers. When I go in, I want to hear their pain points because I know they have them, and so then they'll get to that, the patients with diabetes. I'm getting dinged on those patients because I'm part of this clinically integrated network and I have to perform at this level, and I'm not winning with this patient subset. Or hospitalizations, whatever it is they need, you can then figure out what services you offer that can solve that.
I love that you're almost offended when you hear I'm not clinical. I love it, almost like your reaction is like, no, absolutely not. You are.
And even to a degree that happens starting out in pharmacy school. Like, you have pharmacy school saying, all right, well, 75% of you are going to go practice in the community. We're going to talk about residencies. We're going to talk about hospital. We're going to talk about, and even in the hospital, you have your basement pharmacist and your floor clinical. It's like this natural hierarchies of things that it's weird. And, even like I came out of the renal specialty background. It didn't mean I had any more training. It means I deal with the same 10 drugs over and over again, and I see them all the time. And so it's really smart to say, you're right. I have a PharmD just like every other pharmacist on the planet.
Yeah. We just have to say where our setting is and what we can do with that setting.
We see it sometimes with startups, because we probably see, I don't know, roughly probably 300 to 400 of those a year, and a lot of that time as a pioneer owner like yourself, maybe starting another pharmacy, but a lot of those are just like from scratch startups. And so, and what we've seen is that's kind of an area of focus where they're like, maybe I can offer this to be, like you said, relevant, different, a niche or whatever. So I don't know, do you have any pearls there for like, hey, what's it take to start up a niche and get that niche to even break even?
That's a great question. I think you got to really figure out what you're passionate about.
Right. Okay.
Because you're going to have to work really deeply about it. And a lot of times you got to introduce that, to your customer base. And if you don't have a customer base, how are you going to get the customer base? And because people are going to feed off, what you're passionate about. And so, how you talk to people, like if you want to do these, billable consultations, then, well, that's going to be a foreign concept to people.
Yeah.
Because pharmacists are always free. So,
which we've got to get patients to learn
how
that
are you
that's
going to
not
build
true.
that up?
Yeah. Yep.
To deliver on that perceived value. And, I think the hard part that we have is, as a profession, unfortunately, probably my colleagues won't like me saying it, but we've cheapened ourselves, over the years, where people, they love us,
right,
but they don't necessarily see the value. And so how do we turn the tables on that? And were you able to really shine, with your clinical skill set, and how do you want to apply that? Either do you want to do nutrition counseling,
right,
and build a nutrition practice around that? Looking at your area, and see like who's doing what,
right?
And if like out here, it's of course, we're one of the first states to legalize marijuana, and so it was like, well, is the pot shop going to be the expert in CBD? The hip version,
yeah,
or the guy
probably
who's
not.
Doesn't know diddly squat.
Probably tell you what the ride's like.
I mean, I was going to say, to be fair, he's probably got the most experience with it.
Yep.
Right.
But I think looking at the community and saying, okay, where can I really step it up and be the expert, and so the people kind of know us start to know you for something,
right?
So
whatever that is.
Do you find that it's easier to get patients to translate that value from somebody who's already traditionally compounded drugs are more expensive or less covered by insurance? You've got a group of people who are like, all right, $50. I don't like it, but I'll pay it. And then you're like, all right, well, we have the nutrition service and it's whatever. Are those people more apt to embrace the fee for your service as opposed to somebody who pays a $3 copay?
I think it depends on, what they're interested in, as a consumer. Like we all have our things. Like the person that I would least expect to want to invest in, nutritional supplements, sometimes it appears like you think it's the person who's, very tight with their money.
Right.
But yet they believe in that. So they want to deep dive into it, versus other people, they may not be as invested. But certainly I think that the patients that are paying for customized medicine, like they want it tailored to them, well, they're a natural, invested in their own healthcare, and they're not depending upon traditional medicine to dictate what they get. So they are naturally going to pay more, and they want that. They want that customized. They want to feel good about, how they're spending their money. So that's a great customer. But I wouldn't discount the people that are paying a $3 copay and upset because it went from $1 to $3, because some of that is just they want their insurance companies to pay, and they're expecting to pay, and it's not necessarily that they can't afford it. It's more of a psychological component.
Well, I mean, I'm probably the perfect example, and this is going to be embarrassing to admit, I suppose.
Yeah, I want to hear it.
Like, I'll happily spend $50 on a bottle of bourbon and not even think about it, because I see the value in the craft. And a couple of years ago, I went to the doctor, and my vitamin D levels were 0. Because my wife pesters me about putting sunscreen on when I go out and all that stuff.
Don't blame it on her.
Yeah. we can push that over a little bit. But so
it's not Jess's fault.
So when I went to the store to get vitamin D, what did I do?
bought
I bought the
you bought the
absolute cheapest vitamin D possible,
piece
right?
of garbage on the shelf at some place.
Right. But
Yeah.
I will not buy a whiskey in a plastic bottle, right? It's just not going to happen.
Everyone's a snob.
Because you're
Right.
a bougie lush.
Right.
Yep.
So, I mean, it's true. Like, if you value it, you'll
Yeah.
spend the money on it. It's
That's
just,
true.
how do you find the people that'll value it?
Yeah, and attract those, right?
Right.
Yeah. Yeah, you're right. I kind of always tell everybody, like, it's probably a bad way of putting it, but everybody's a snob about something. You know, like it could be a car, it could be tools, it can be whatever. And I say snob like a
I feel
bad
like that was a personal
connotation.
jab. On the
But it, it really could be. It could be gloves, whatever it is. But you have, and it's building probably that type of pharmacy and messaging and delivery of said service to attract the folks that you're trying to attract.
And I think that looking at the healthcare providers in your area, and I'm not spending 2 minutes of my time going to, the large family practice clinic that's churning out hundreds of patients a day. I mean, they're giving people individual attention is just not their business model. And so you got to be wise where you spend your time and looking for. And it used to be like, hey, the independent practitioners, because they're trying to make a name for themselves. They're trying to build their own businesses.
And they're like you, right? Yep, kind of thing. And
they're like that. But like independent pharmacies, independent physicians are dwindling.
Yes. Probably at a faster rate, right? Like,
right.
It's getting harder for them. And they've had to learn to scale themselves with either nurse practitioners or PAs or whatever to like, I think I've had 3 minutes of FaceTime with a doctor in the past 24 months. You know what I mean?
Think, okay. So just to kind of go back to y'all talking about, value, and Mark saying people are a snob about things. I think being a snob about some of the products you guys are interested in, you research a lot into bourbon and the process and all that stuff. But the problem
That's
with
the nicest way anybody's ever said I drink a lot.
You drink a lot.
you drink a lot. But I mean, with patients, they're not researching their prescriptions. They're only researching the side effects. And so how are you working? I mean, give me one of your patient success stories. How are you convincing the patient the value of this and going, no, you need this supplement to counter with this medication?
The value of what we do is learning how to listen and engage people and talk to them. Mm-hmm. And that's the big benefit that I have that some of like the chain pharmacists don't have. But listening to people and talking to them about what's going on, because a lot of times they'll start sharing information with you. And then when they realize, oh, I have time with you, now I can really talk to you and ask questions that I forgot I had.
And so when you look at what's available to us, we should become the wellness centers for our patients, and they will pay you for it. And I know I hear this all the time. You don't understand. My patients won't pay. They won't pay the $2 copay. They're not going to spend any money on their health. Well, the deal is they will. And I know they will because they do it with me. And so now let's look at it a little differently. If you have 3,000 active patients in your Pioneer system today, and I consider an active patient as somebody that's bought a prescription in the last probably 120 days, and you asked 100% of those 3,000 patients, would they like to become their healthiest? And you're going to help them optimize their health through these mechanisms that we do. Could be with some testing. It could be with just the top 6 or so supplements that people need. You can start wherever you want. And those 6 people spend an average of $300 a month, and they will. That is $1,080,000 a year at 50% profit. How does that look for your pharmacy? In the scenario I just gave you, you asked 3,000 people and you got 90% no's, only 10% yeses. So you can't be afraid of getting a no. And your goal should be to give that patient a customer experience. Customer service means I smiled at you and said, thank you for your business. Customer experience is when they leave, they don't remember what you said or did. They remember how you made them feel. And if you're there helping that person become their healthiest, they're optimizing their health, and you're fixing their gut, you're getting their, vitamin D, just vitamin D alone. If you get a woman's vitamin D level to be maintained above 50, which is not optimized, by the way, it's just above 50, they have a 50% less chance of having breast cancer. I mean, this time of year, every pharmacist should be selling vitamin D. A rule of thumb is 45 international units per pound, and give it with vitamin K2. I mean, easy peasy. Vitamin D3 is 85% more absorbable. So it's a really easy way for pharmacists to increase their sales and help your patients, which is your job. And I think after you know this information, it's really malpractice not to.
Yeah. So every single patient that walks in the door is spending their money on things that align with their value system. So whether their core values, are triggered by, things that, going out to nice restaurants, or if they're, a collector of something, or whatever their value system is, they're spending money. So how do you get that patient on board with understanding that, how do you bring their health into that ring of their core values enough to tap into their financial pie?
Great question. And so you have to remember, as a pharmacist, your job is to help your patients optimize your health. Your job is not to fill prescriptions. That just happens to be part of it. So you should be able to fill prescriptions, do testing, do supplements, explain to them, the importance of exercise. So you have this whole range of things that you can do for your patients. And these people are willing to spend the money to do that. Now, not all of them are, but enough of them that there's bazillions out there. And you have to remember, people spend money on what they want to, not what they have to. If I go to the doctor and they say, you got high blood pressure, you got diabetes, here's your pill. Well, that's a have to. I didn't want to hear I was sick. I don't want to pay for it. My insurance should do it. But if they want to buy organic and spend 3 times as much for it, they do it. I have patients that benefit so much from CBD for like neuropathies or something, or Parkinsonism, that they're willing to spend the money, and they're on Medicaid. They give something else up to do it. And so people will do it when they have the need to. And I believe, and this is crucial for me and how I operate. When you come in and you get in our system, we want to test, treat, test. So test, therapy, test. Therefore, I can prove to you the time, money, and effort you spent, you're healthier. And that's the cornerstone of everything we do. So if I'm not getting success to you, you shouldn't be paying me.
All right, so I see this big foundation dropping. Bam, this video, MedSync, right? What's next? All right, so I got the MedSync thing going. What's the next thing?
So immunizations, obviously very involved with that, have been since, we started immunizing in Virginia, really, back in 1997. So I remember when my dad ordered his first vial of flu vaccine, like literally we ordered like 5 vials for a season, which cracks me up. I could do 5 vials in 20 minutes now. But that was back when we were first starting. And so really growing that, because we know that is a lucrative business. We know that adult immunization rates are down even before the pandemic. And so it's important to, when you've got those patients there, can you maximize their health and wellness? So that's a big part of what we focus on too, is health and wellness. So obviously immunizations fall into that. So I think that's a good next step.
All right, immunizations. What's next?
Disease state management. So your sync patients, is there a way for you to divvy them up, and how can you help them, and what services can you offer maybe some complementary services that bring them in the door and then kind of build on those. So we do clinical initiatives like blood pressure, osteoporosis, cholesterol, and diabetes screenings that are part of our program. And then when we get them in the door, when we get them thinking about chronic disease a little differently, then other things we can offer them, diabetic socks, shoes, and other clinical programs that we offer.
Yeah, I can. And then kind of the next thing, as you think about disease states, you kind of think about who you're working with in town. And another kind of show me I think I could see is this whole getting you out of the pharmacy.
Getting you out of the pharmacy and
right?
creating relationships with
taking them, coming out with a strategy of, hey, we're going to come and these are the places we're going to visit. We're going to go visit public, try to do some video with them. Really saying, hey, your outreach. If you're not, if you're a community pharmacy and you're not in the community.
I'm putting Eric Larson on their plate because we were there for a really cool success story about the COVID vaccines. We were there when he got the call from the state because the big box chains were not getting it done. And so the state health called Eric Larson and said, we've got COVID vaccines. Can you get them dished out
Public
today?
Health had a deal, and that's who they turned to because they had the relationships. And that's what I think it'd be fun to do, a show that's helping people learn how to build those relationships. And you could see even, if you could get some local people engaged, like Public Health engaged, and where you could come in and video that as well. Because I think it'd be a good sales pitch to tell Public Health, hey, we're filming this thing to help pharmacists learn how to work better with their public health department, right? And I think they'd be in on that.
When you look at a patient with, 4 or 5 medications, and each one of those medications, you have, the patient calling in for a refill. You're moving that prescription through data entry, fill, verification, will call, notifying the patient, having a point of sale transaction or delivery. That's 7 different touch points on one prescription. So with 4 prescriptions, all of a sudden you're up to 28 touch points. It's hard to decide which one of those 28 touch points is going to be the one where you get clinical and concentrate on a med rec and concentrate on, really moving the needle in other areas. So definitely that MedSync so important.
Yeah. And I think it gets to that appointment-based model too. And then that chance to have that interaction with the patient to see how they're doing, right? To get information from them about how are things working? Are you having problems? And by scheduling that every month, then you're definitely going to have that conversation with them. So I agree. I'm glad you touched on the technology part, because one of the reasons we are still baby stepping with MedSync is because we have tried and failed with other systems in the past. And it was very frustrating. And then it's hard to convince your team, okay, we're going to do this again. But it is working now. And we're very pleased. It does take patience though. So for anyone who is just getting started, let's encourage you that don't give up. Don't give up. Like the beginning is probably one of the hardest times. So just, set a goal, 5 patients a week, whatever it is, set a goal and just keep persisting. And there will be patients that fall off that program, and that's okay. You're going to have failures. That's okay. Not every patient's a perfect candidate for sync, but keep it up.
Yeah, so there's definitely a point where it tips, where if it goes from having a difficult change, because any change is a challenge. So there's a point where that starts to pay off at a certain percentage. When you get around 25, 30%, I guess it starts to all of a sudden clear the schedule a little bit.
Yeah, absolutely.
So when you do have that appointment-based model, what benefits does that give you practically with the patient? Like, how are you capitalizing on that appointment-based model, and what services are you able to offer in that appointment?
So one of the things you could do is if they do have a medication therapy management opportunity, then that's a great time to catch them then. and do that. Also immunizations, and I will be honest that we're not as good at that as I wish that we were, but that's a great chance to, to speak with them about what they're current on or what they might need to have. So those are just a couple of examples of things that, you could add in at that appointment-based model. But I also think just having that question, are you doing okay? Is there anything going on that we need to know about? Because, we can make an impact in their care that way too. Perhaps they do need a change in medication. So, that's the chance for the pharmacist. If the technician who's calling finds out that there's something going on with that patient, then that's a handoff to the pharmacist to have a little bit of a deeper dive as well.
Kind of walk me through how, a patient might, move through, a new patient might move through the workflow and how something, that may traditionally, look like, okay, this is going to be, a patient with a lot more touch points. It's going to be much more clinically demanding patient. How do you integrate that in and make it all work?
Yeah, so actually that comes from, and I'll tell you right now, I'm the biggest Pioneer fangirl you're ever going to meet. That comes from our lovely Pioneer system. And I will tell you, not to call myself a super user, but but I use Pioneer at a pretty high clip to do a lot of automation in the pharmacy. So if a patient comes in, like let's say for example, they're living with HIV, they've just come down from seeing our providers and a prescription arrives. One of the first things that we do is we start with some intake information. I'm a huge data miner, so I like to get a lot of information about the patient, their race, their ethnicities, their backgrounds, and things like that. So that way we know how we can help and reach out to patients in a much better and more efficient way. Data really can drive pharmacy in a huge way. So I can't stress enough. I know a lot of pharmacies don't dive into demographic and things like that. It's super helpful because it lets you know how to target your marketing, and it lets you know maybe who you are and aren't reaching. You don't know what you don't know. Anyway, we have a patient that'll come and present at the counter. We do our intake form. We get their data entry process started. From there, if the medication is categorized, I love me some auto categories. If the patient is categorized as one of our patients from our providers, and the medication is categorized as a specialty patient, care goals start to trigger automatically.
Gotcha.
And we're an accredited specialty pharmacy, both through ACHC and DURAC. And so we have to maintain level and points of contact with these patients and levels of care with them, including an initial assessment to make sure that they're going to do well on their medication and maybe they're going to stay adherent, or identify some tools and things that we could use to help them with, as well as doing monthly follow-ups and making sure that, when we're filling this medication, that we're still on goal for becoming undetectable, which is always the goal for HIV care, right? And when we do all of this, Pioneer triggers these things automatically. So throughout workflow, we will have things that'll pop up and say, okay, this patient needs to get an initial assessment, which will then let the pharmacist know once we get to the point of sale, we've got a full block. At that point, we'll take the patient into the counseling room. The pharmacist will sit down and do an initial assessment. And again, talking about that pharmacist maybe being able to do that 30-minute counseling with somebody. I've got 2 more pharmacists ready in the background, right? They're still in the workflow. Yeah. This is a really unique model. So being able to have that pharmacist be able to privately meet with that patient and assess what their health goal looks like, and what do you want big picture, and what can we help you do to meet goals? How can we help you? Are you struggling financially? Is there ways that we can find other things for you to help with the costs of your other medications, right? And those are the types of things that we sit down and do. And what will happen then is once we close those care goals out, depending upon the status that we use, it'll trigger again the next time that they fill. And so we get these wonderful triggered cascading reassessments and initial assessments when a new drug or a new therapy is started. It is absolutely fantastic. So again, fanning out for Pioneer. Pioneer really does make my workflow go very, very well and very efficiently. And it keeps it so that way I have a great record for my patients. And when a patient comes in and talks to us, it's not like we don't remember who they are. I can pull all of it back up. And oh my gosh, I remember when you talked to me about this, you were going from first shift to third shift. And so that makes sense that you're not remembering to take your medications. Let's start a care goal. We'll follow up with you weekly. And that pops up in the trigger and the cues automatically based off of settings. And we can just follow up with patients and help them live their best lives and get their best possible outcomes.
Yeah, I think that last topic especially is something we haven't really visited often on this podcast, but it's such a huge slice of the healthcare spend and socially such a scary and difficult and expensive and estate wrecking expense. But that geriatric care and facility management, like if you can keep somebody adherent, if you can keep somebody on track and managing their disease states, if not defeating them, but at least, staying home and aging in their community. There's such a huge need for that on a healthcare spend, on a social spend, on a heartstrings pull, that, in all of those areas that really I don't see that anyone but independent pharmacy can fill that. And so how do you think that independent pharmacies can, really convey that value? Are there metrics or opportunities there?
I think that's the next frontier. I mean, I think, that's that whole realm of the medical at home, and we're trying to figure out how to, justify so we can get paid to cover those services, because we're doing kind of the same services as we do in long-term care. However, I think the best places to go out and partner is with home health agencies, all right, that are trying to do the same thing, keep these people at home. Even group homes and personal care homes, which they're a lot of times based in that person's community. They can only take care of people if they can at least do the basic things. And if you can help identify. So for example, one of the things, and I know that we don't do this yet at Clinicians, but in putting on my old geriatric hat, is fall risk assessment. There are many medications can lead to falls. There's much data out there. If you're on 2 or more CNS type of drugs that, cross the blood-brain barrier, get into your brain, you're at higher risk for fall. Somebody breaks their hip, all right, their life expectancy may be less than 5 years based on some of the data out there. So just identifying falls to be able to, the other thing is marketing it to caregivers such as family members, I had a great grandfather who lived 6 months shy of 100, and I had my other grandfather, pass away in his early 90s. And both of them lived at home pretty much until the end of their life. And, my great-grandfather slipped and fell, all right, and broke his hip. And kind of the trajectory of his last year and a half was, having to go to a home. And my grandfather hurt his back, but for a long time, they were able to stay at home because they had caregivers. They had somebody manage their medications and being able to do that. So, a son or daughter, if mom and dad lives in the same town with them or whatever, they would rather be able to go visit them at their house than, having to go to a nursing home, which that's not always the greatest environment to go visit a loved one. And sometimes they're isolated, things like that. So, I think doing that med rec, there's lots of programs. You don't have to go do a geriatric residency to be a geriatric whiz, but there's lots of programs of, identifying, there's, the Beers criteria, the stop criteria. They're not perfect, but they guide you. What are bad drugs that elderly people shouldn't be on? What are things that put them at risk for falls? Just getting them adherent. I think those things we could do well because we have that access point, or that. So, I speak passionately about it, but I know we could. And I know that from experience, from what I've done in my residency, what I've done in geriatrics, and I always tell a story, and I did a CE at our state association on medical at home, because I think this is the next realm. And for the medical at home is what we were talking about earlier. You bring somebody on board, you do a good med rec, you look at their medication regimen, you simplify it. ask the simple questions. Have you fallen in the last couple of weeks? And when you fell, did you break anything in the last year? Do you get dizzy when you sit up? And then just look at their meds. And, there's enough software out there you can identify. But when I worked with the hometowns, we had a pharmacy resident. And this pharmacy resident, was working with this lady that was down the street, and she had some early dementia, but she could take care of herself. And we actually simplified her regimen. And we didn't have fancy adherence packaging then, but we actually had 7-day, pill containers. And we simplified it to morning and evening. And she and her daughter, who lived in California, kept wanting her to go to California, and she didn't want to. She wanted to live in her community. She went to her local church every day. She went to the senior center. And by doing that adherence packaging, she stayed there for about 3 years. I don't have true scientific evidence that was it, but the community and her neighbor looked after her.
Yeah.
3 years later, she had to go she ended up flying out and living with her daughter. And I can remember this same resident actually worked for us, and she said, "You know what? I guess maybe we failed." I said, "No, we didn't fail. She got to live 3 years of good quality of life the way she wanted to live." And I think that's something that, all community independent pharmacists take pride in their communities. And I think that's something that's the next big area to do. And, the tools we have to be able to just putting people in adherence packaging facility, med syncing, they're all there for us to be able to take advantage of this.
We have to be prepared to measure the long-term effects of what happened to humans in the pandemic. And a lot of that won't be realized until
years,
later down the road. I mean, even if you think about schools, what happens when you what happens when you don't really have day-to-day school for a year?
Yeah. No, my kids are going through that now. They're both remote learning and have been since the school year started, and they are, they're some days they're great, and then other days are on the struggle bus. You just need some sports helped with some of that for them, and yeah, you're right. What kind of long term? I really think about that kind of stuff. What kind of long term effect does that have, either on relationships or just mental health in general? How you deal with stuff,
socialization.
Yeah.
Right. Well, and this kind of will wrap it back into like measuring social determinants of health. We're all lucky enough to have jobs that we still got to keep through the pandemic, and our kids have the ability to, stay at home in a safe place with good internet and
nutrition,
and learn their class.
Right. And having,
but there's a large
nutrition.
number of kids that go to school where that's the only place they've been safe that whole day. That's the only place they get fed that whole day. And they don't have cable or internet or anything else at home. And so you've got this huge gap of kids who have the resources and those who don't. And it's just amplified over this last year. And what does that look like? Those kids are going to go from 5th grade to 6th grade, and next year they're going to be wholly unprepared to stay up with their cohort.
So I went to a provider recently, and the check-in was super I'm like, oh, this is SDOH screening. And I know that there's a lot of discussion because there's so many touch points with the pharmacy, is what role could pharmacists have in this screening? Number one, and what standard type of tool should be used? And then, how do you triage that? I mean, it's irresponsible to collect the information and then go,
and then just go, I got it now.
Right.
Oh, they're food insecure.
Right.
Right. That's, the last couple of PQA leadership meetings have really focused on social determinants. And everybody really, it's super interesting. It's really powerful. It's probably the biggest driver of improving healthcare that we haven't touched yet. And we still don't have any idea how to do anything with it. At least not for real. There's a lot of places where they're piloting things, but okay, so I know this child doesn't have food. How do I fix that? So from that end, just kind of what you're looking at, what do you think is the most important social determinant to measure in community pharmacy right now? whether we can or not, just if you had a unicorn, what do we measure?
Which one?
The most important one.
Only one.
Just one.
Only one.
You got me,
Goodness
Josh.
gracious.
Totally stumped
Yeah.
me.
I mean,
No kidding.
I'll loosen up. You can give me top 3. That's fine.
No. Back to you, Josh.
All right.
Tell me.
I like that. How about you, Josh?
I don't know.
Okay.
All right.
I know. I would say that I don't know what that is. PQA is collecting information, and we have initiatives for 2021 to evaluate social determinants of health that could be captured by pharmacists. What's being done, what makes sense.
Hopefully you start with...
I don't know, transportation, food. I mean...
I was going to say transportation, income level. I mean,
right. Yeah, I mean, one of the areas I think pharmacy can make the biggest impact on, I don't know if it's the most important one, but it's transportation. Right? Like between being able to deliver a medication to a person or be able to, in theory, mail it to their house, you lose a lot of clinical impact at that point. But, delivery is a great way to kind of overcome that. And it takes back to where we measured social determinants in renal care prior to me being a pioneer. Medicaid will pay for transportation from a person's house to their doctor's office. They don't pay for transportation from their house to their pharmacy. So we addressed that by delivering medications directly to the dialysis facility so the patient could pick them up in person. But there's a lot of places where you can't do that, right? I knew where they were going to be 3 days a week for 3 hours a day, but not every pharmacy delivers, and not every patient's within delivery range of a pharmacy.
Well, I'll tell you, with the pandemic, as the pandemic was unfolding in March and April and beyond, I started to interview health plans to see how the pandemic was affecting potentially their quality ratings for the future, and just listened to how much pharmacists and pharmacies have stepped up from the health plan's perspective. In terms of delivery, access, of course, there's testing, and ultimately the immunization will be huge. And back to the social determinants, MTM pharmacists have been conducting questions around, obviously, the pandemic opens the door to a discussion about how is this impacting you, but more of those social risk factor questions and triaging. So there's a lot of opportunity, and this crisis has really shed light on it for sure.
Can you give me a for instance? Like, give me a for instance of I recorded this information. I did my SDOH review. Give me a for instance on when you triage something, or if you had the ultimate resources, right? Like to do that.
Yeah. So the case, kind of the scenario that I'm talking about is a pharmacist who is working for or with a health plan.
Right.
And so
like an IDN.
Yeah. So there you have the infrastructure, and you can successfully triage to a case manager right.
Okay.
So there's that infrastructure in place. So what that looks like everywhere else, will likely be a little bit different.
Right. I think with our firm, it probably is relationships. It's building those relationships you have with either your public health departments or whatever to address your food banks, right? To address nutrition or transportation. That's where we had Trip Logan on talking through. He's like, he kind of gave us a list of 3-4 different entities in your community. You really need to know who they are, and it really helped him. It seems like, one, just from a business perspective, but two, to be able to address and, to your point, triage where needed.
Yeah.
Right. And that's where you get spoiled when you work in, integrated care.
Right.
When my patient said, I can't get to X or I don't have enough food, we had a dietitian that we could refer to, or a nurse case manager. That's how do you build that virtual toolkit to refer to a team that doesn't work for you or with you.
Right.
Yeah, I mean, there's definitely luminaries like Tripp who have.
Yeah.
That's what good looks like.
Right. Yeah. Yeah.
We'll have to tell Tripp and put that little, cut that out and send it to him. Like that's what that's what good looks like.
I like that. Yeah. Yeah. They can do some graphics with this later.
I try to always look at things from a business perspective as well. I make sure first and foremost, we always take care of the patient. So we do what we need to do. And then on the back end, I feel that's somewhat of my responsibility is how are we going to get paid to do this? But I don't want to go full steam ahead if there's no mechanism to get compensated for it either.
Yeah. I mean, and today it's interesting that there are definitely some initiatives, some organization is really what it's going to take is that, being able to standardize and provide in a uniform way. Here's a way to quantify those services. And that's exciting to see with, flipped pharmacy and CPESN kind of moving that needle forward.
Right. And we've made a lot of progress in the past year, I would say. And I'm hopeful for exponential growth of that because I think with COVID, it has shown how community pharmacy really plays a vital role in individual communities' health and how do we leverage those resources that we have already in the community. And in Ohio, I want to say the managed care plans have recognized that and really want to take advantage of it.
Yeah. Well, I mean, COVID's been, if there is a silver lining, it's been great for independent pharmacies to be able to illustrate their value on a larger scale than ever, probably.
Correct.
So,
and some of the other things that we're doing, my wife's very passionate about what we do with our severely mentally ill patient population. Just for the fact that some of the things that we take for granted, adherence calls when people don't have steady housing, places to eat, all those things introduce other challenges. But so what other opportunities can we take advantage to engage that patient to make sure that they feel comfortable and we're reaching out to them in a means that we can connect to them to keep them on their medications, because a lot of the medications they take cause other disease states. You're dealing with their mental illness. Now they have diabetes, they have hypertension, high cholesterol. So they become a very complex patient that needs to be treated as a whole patient. So, I'm very proud of what Ann and her staff have done at that location from a standpoint of looking after that patient and being that pharmacy that's going to look at that patient, not just from one disease state, but the whole patient.
Yeah, so let's dig into that a little bit. So when you're at the original location, and it sounds like early on you saw that need in the community for assistance with the mental health community, and then you start performing those labs and you start providing more and more emphasis on that. Eventually, that grew into a whole nother pharmacy. But I'm really curious of how you're able to make that work and how you're able to grow that while still keeping your eye on all of the other parts of your pharmacy that were, already a full-time concern, a full-time area of focus. So, did you delegate? Did you have a team member that you made a champion of that early on? How did you, because you have so many different niches that you perform, I'm curious how you really are able to keep all of those just moving forward so strongly.
Well, I think part of it is just understanding I can't do it all. So really I have focused on having a staff of managers at the pharmacy locations. And then I have Dan, who's vice president of pharmacy operations, and he oversees the day-to-day operations of the pharmacy and making sure that we're doing everything we can. He's staffing 2 to 3 days a week as well across the 3 different locations. But it's been vital to build in some infrastructure. And I think that's what I've learned over the years when I was trying to staff 40 hours a week and do everything else. It's just hard to keep your eye on the ball when there's different balls bouncing at the same time.
Yeah, I remember when I came to visit your location the first time as an installer, and at that point you were only in part of the building, but I think you were beginning the expand to expand into the other part, and I just remember being a bit overwhelmed by the like kind of the different sections that you had. So I remember, a nice retail area where you had everything that you would typically pick up at your neighborhood drugstore. So you had that great kind of community experience. And then you had a packaging device. And then downstairs, I spent a lot of time with those Oki Data printers for your pouch packaging.
That was switch.
Me too. Every now and then when I hear an Oki Data off in the distance. So I feel like we're going to need an appendix for anybody who's like, under 30 for diskettes and Oki Data printers. These are just Googleable. They're Googleable.
We just got rid of our last Oki Data in 2017, Will. So, I mean, we were still using them until we installed the new automation and the new closed-door pharmacy we opened in 2017. So,
yeah, I mean, so, they're a bit dated. They still make these Oki Data printers, and they're still exactly the same as they were 30 years ago, but they're solid. They work. And that pill packing system was, it was pretty versatile. I can definitely see some of the advantages of that. So let's talk about that in itself for a minute, because you had a whole rack of these printers, and you had been doing that probably since, those Oki Data printers were pretty state of the art.
I mean, we started doing, I even cringe to say it, DocuDose packaging in the mid-90s, when we identified that with the mental health patient population, they had a real struggle with medication adherence. So we were doing that for 20 plus years of using those Oki Datas and printing the DocuDose bags.
Yeah, which is a really great way to step into the adherence packaging realm. It prints directly from the software. But yeah, the printers are definitely a bit of a throwback. So what did you end up moving to?
SynMed.
SynMed, yeah.
And the reason is we wanted the flexibility, and that was the automation that provided us the most flexibility. It can do 40, I believe, different packaging styles. And right now we use 3 different packaging styles. We use Dispill for some patients. We use the 30-day cards for some of our group homes, and then we use the multi-dose cards for the majority of our patients. But that one piece of automation, by just switching the trays, gives us the capability to produce those 3 different cards.
Nice. It's always interesting to hear, which specific device has worked best based on your needs, because obviously, a different automation solution may be better for somebody else or better for you. So it's always great to kind of hear specifically why that was a great tool.
And what I wanted to look at too is the competitive landscape. What was going to differentiate us in the market compared to our other players? All the other competitors in our area are using pouch systems. So I wanted to use a different type of solution that would make us stand out compared to our competitors.
If you enjoyed today's episode, please like, subscribe, and follow us wherever you get your podcast.
Give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.